Well, welcome everybody. Thank you so much for your warm welcome, Rob, and I'm absolutely delighted to be able to present to you today. You'll see from this opening slide that I've put the following title to my presentation. The past is behind. The past is behind. Learn from it. The future is ahead. Prepare for it. That's a really broad subject, so we have a lot to cover. But before we get stuck into it, let me tell you a bit about myself, which I won't go through that all again because Rob has done that very kindly for me. But you'll see from the details on that slide that I'm not a clinician. So I'm not here today to try and help you improve the way you conduct your clinical business. But you'll see from the slide that I've worked within the Australian private health sector in a variety of roles and settings. These roles have included some fairly senior leadership, governance and management roles. In these roles, I've had to interact with senior policy makers, both in the federal and state governments, and also within the various health professions themselves. These experiences have helped me gain an appreciation of many of the issues that health professionals and their associated colleges and societies face today. So I'm not going to pretend that I know much about podiatric surgery itself or the college, but what I can say is that I'm very confident that the pressures and challenges that you have faced and will face in the future will not be that different to the pressures and challenges that many other professionals and their colleges are facing today and will face in the future. I'd also like to share with you, before we go into the body of the presentation, some of the enduring impressions that have been imprinted in my DNA as a result of having worked for more than 30 years in the Australian private healthcare sector. And I'm very confident that whilst podiatric surgery is different to other sectors that I've worked within, my enduring impressions will have real relevance to your particular sector. So what are these impressions? I think the first one is every different subsector within the overall health sector is able to put forward compelling and sound reasons as to why their sector needs more funding, and with such funding it will be able to make a big difference to the patient cohort that it treats and services. Secondly, there never has been, and I suspect there never will be, enough funding to meet all these specified competing needs. Consequently, whatever funding that is available is always going to be highly contested for. Some kind of rationing is always going to take place. Moreover, and this is important, decisions relating to how available funds are to be allocated do not always result in the correct amount of funds being made available to the most deserving and cost-efficient services. The next one is no surprise to anybody. The demand for increased health services is insatiable. The demand simply cannot be fully met. This demand is driven by many forces, including patient need, patient demand, which is obviously a little bit different to patient need, global population growth, which fortunately is only very modest in Australia, the aging of various population cohorts, which is of course particularly relevant in Australia today, the ongoing advances in medical science and technology, and then finally the increased activity of healthcare corporations on listed stock exchanges. And then finally, the healthcare sector is extremely complex. It's complex from a medical science point of view. It's complex from a social and human point of view. It's complex from an equity point of view. It's particularly complex in Australia from a funding point of view. And in Australia, it is fragmented, and this makes it very difficult to navigate. That means that if a particular sector, such as yourselves, is not prepared and able to advocate for itself, it is highly unlikely that anyone else will do it for you. And such a sector will consequently be at risk of becoming lost and invisible both to the patient and to the policy makers and funders. So, with that as a bit of backdrop, let us now turn to what we'll be covering today. First of all, that's the rough time frame we'll be working through. I'll try and keep to it, but if necessary, we can either make the coffee break shorter or longer. So let's get down to business. But before we rush headlong into looking to the future, it would be helpful to briefly look back over the last couple of decades to remind ourselves of where the college has come from and what have been its major accomplishments over that period. To assist my understanding in this respect, Rob has given me a number of documents which describe your history in Australia since Y2K. Prior to the year 2000, it's probably fair to say that despite international evidence showing that the safety and effectiveness of foot and ankle surgery when performed by well-trained surgical podiatrists, foot and ankle surgery in Australia remained largely the domain of orthopaedic surgeons. This is prior to 2000. Based on the research that I've done, it seems to me that the college's major achievements over the last couple of decades have been training and accreditation. As you all know, podiatric surgery has been a recognised profession in Australia since 1976. But it was not until 2010 that it was nationally recognised as a surgical speciality. This national recognition occurred with the introduction of the National Health Regulation by the organisation known as the Australian Health Practitioner Regulation Agency, or AHPRA for short. Recognition by AHPRA was a big deal. In a sense, it signalled that podiatric surgery had come of age from a federal health policy point of view. Such recognition means that surgical podiatry is now well and truly on the public health radar. That's why it was a big deal. I'm sure achievement of such recognition was not easy. It was only achieved after a lot of hard work and advocacy by a few dedicated individuals. Underpinning such recognition would have been all the hard work that occurred in the late 1990s into the development of a robust evidence-based training program. As you know, the body in Australia that is responsible for granting specialist recognition as a podiatric surgeon is the Podiatry Board of Australia, PBA. There are various pathways which will enable a candidate to achieve such specialist registration as a podiatric surgeon, and Rob touched on that in his opening remarks. I'll shortly outline the process that applies if the candidate follows the college's specialist pathway. But we should remember that many podiatric surgeons, and no doubt there's some here today, have been granted specialist registration by following the doctorate pathway that applies in WA, or by having the overseas specialist qualifications and experience recognised by the PBA. From what I understand, the college pathway requires the specialist candidate to first complete a 4-year undergraduate degree. All undergraduate podiatry degrees incorporate general and surgical studies, as well as specific content relating to pathology and diseases affecting the foot and ankle. Following achievement of their degree, the graduate may then apply to be registered as a general podiatrist. To become a podiatric surgeon via the college, the podiatrist must first practice as a general podiatrist for 2 years and complete a postgraduate master's degree incorporating additional studies in general medicine, surgery, pharmacology, etc. Candidates with a master's degree may then apply to sit an entrance examination with the college, and if successful, may then enter into an accredited training program as a registrar. The length of time to complete the specialist training will typically take about 8 years following registration as a general podiatrist. During this period, the candidate will be directly involved in about 2,000 surgical procedures. Once fellowship is obtained by the college, the podiatrist may then apply to the PBA for specialist registration as an accredited podiatric surgeon. Thus, it seems to me the training to become a podiatric surgeon in Australia is patently rigorous and robust. Of that there can be no question. But it does, however, strike me as very odd that despite such training, and despite the fact that podiatric surgery is recognised by AHPRA as a surgical speciality, there is currently no Medicare funding, I repeat, no Medicare funding for podiatric surgeons, irrespective of their qualifications and experience. That is very bizarre. So let's talk a bit about funding. I think I should first clarify my statement when I said there is no MBS funding support for podiatric surgery. That is correct. But that is not to say there is no MBS funding for general podiatry. That is not the case because PBS rebates for general podiatry were first introduced into the NBS in 2004. There were, however, significant limitations to that funding, and these still remain. The main limitations are, firstly, the rebates are designed to only apply under a regime designed to improve the quality of the chronic disease management of a GP's patients. So the GP is the gatekeeper. The way the funding is organised is that it permits specified allied health providers, including podiatrists, to comprise part of the clinical team tasked with managing the patient's chronic disease. Secondly, the Medicare rebate is very modest. It's currently only $55.10, and that's probably for an hour, and it only covers consultations. Thirdly, the Medicare funding only applies for 5 consultations per annum and only in relation to chronic conditions. And the limit of 5 services per year applies to the consultations by any allied health provider who's involved in the management of the patient's chronic condition. Around about the same time, then Health Minister Tony Abbott moved to recognise podiatric surgery by making relevant changes to the Health Insurance Act. These changes enabled private health insurance funds to insure patients for the hospital treatment costs associated with foot and ankle surgery performed by podiatric surgeons. Whilst this amendment did not provide MBS rebates for the fees charged by the podiatrist himself or herself, it did, however, allow for the first time hospital costs associated with surgical podiatry to be covered by private health insurance funds. This was important because it meant that providing a health insurance fund and a private hospital or day hospital were able to reach agreement on costs. These costs were now able to be shifted away from an insured patient to his or her insurance company. Unfortunately, and despite the intention of the relevant legislation, the experience to date is that the vast majority of private health insurance funds, with the notable exception of HBF and WA, have not reached no-gap agreements with private hospitals or day surgeries in relation to hospital costs associated with surgical podiatry. This means that insured members are still incurring substantial gaps on their hospital private charges, once again, with the notable exception of HBF and WA, and they've got no cover at all in terms of the surgical podiatrist costs. So let's talk a little bit about data collection. When one begins to have dealings with funders of health services, such as Medicare or private health insurance funds, you soon discover that without robust data, your chances of success are like trying to nail jelly to a tree. So it's very pleasing to note that the college has had in place for many years now a robust data collection and audit regime. In fact, I had the privilege to sit in on a meeting at which your 2020 results were discussed. These results covered 2,300 surgical procedures and looked at various matters, including readmission rates as a result of medical complications or post-op infections, post-op DVT events, wound breakdown, and complex regional pain syndrome. The audit found that the reported complications for patients who had undergone podiatric surgery were either within or below rates reported in the relevant literature. I'll say that again. The audit found that the reported complications for patients who had undergone podiatric surgery were either within or below rates reported in the relevant literature. Then finally, let's talk a little bit about pharmaceuticals. For many years now, Australian podiatrists with general registration have been able to administer, obtain, possess, etc. a range of S2 and S3 drugs for treatment of podiatric conditions, and they may also be authorised to possess and administer local anaesthetic agents as per the state and territory legislation in the jurisdiction in which they practice. In addition, in some states, including in South Australia and I believe in WA, podiatrists have also been able to prescribe a small range of S4 prescription-only drugs since the late 1980s. In 2009, new national rules came into being under which endorsed podiatrists were able to prescribe a limited list of medicines. Endorsement identifies those podiatrists with specific additional qualifications and experience, and the body charged with the task of endorsing podiatrists to prescribe these scheduled medicines is the PBA. However, prior to 2018, only a very small percentage of registered podiatrists, in fact less than 3%, had gained such endorsement. The reasons given for these low endorsement numbers related mainly to barriers to training, including mentor access and supervised practice opportunities. As a result of these low rates of endorsement and the perceived barriers to such endorsement, in August 2018, the PBA implemented revised registration standards for endorsement for scheduled medicines. And it is hoped that these revised guidelines will lead to more podiatrists being endorsed with prescribing rights in the future. So that's looking in our rear view mirror. Let's look ahead. Now, in terms of looking ahead, I've chosen a few issues to focus on. Now, these issues have been around for some time. They are not new, and as such, I'm very confident that they've been thoroughly investigated and reviewed by the college, and you're probably pretty familiar with most of them. Today, we won't have time to fully canvass the issues in detail. What I would like to do is to suggest some alternative strategies or ideas that should be further investigated to see if they should be pursued further. Some of my ideas may be a bit controversial. That goes with my nationality, I suppose. That is okay. It's quite okay to put forward new ideas for discussion, even if such ideas are found to be based on incorrect premises or are impractical or unachievable. It is the discussion what is important. Such discussion will help validate or bring into question existing assumptions, and such discussions may also help identify possible new strategies that should be further explored. After our coffee break, we'll be able to further explore some of these ideas that you've probably all got your own views on. As we explore these issues together, please remember the title of this presentation is Learning from the Past and Preparing for the Future. So, let's bring up the first one, the good old thing about funding. I'm sure this must be a pressing issue for you all. How can it really be that, having been recognised as a surgical specialty by AHPRA back in 2010, that's 12 years ago, the MBS still does not provide rebates for surgical procedures when performed by accredited surgeons? I understand that the college has invested considerable time and resources in putting together various submissions to MBS's Medical Services Advisory Committee, or MSAC for short, for podiatric surgeons to be given access to specified MBS item numbers relating to surgical procedures that they perform. The latest of these submissions was submission number 1344.2, which was considered by MSAC back in 2020. I've read the submission and its earlier variations, and I've also viewed some of the evidence that was considered by MSAC in reaching its decisions. And you would appreciate that there was a lot of contrary evidence given to MSAC other than the stuff that was provided by you guys. As we all know, the submission was rejected by MSAC at its meeting held on the 3rd of April 2020, and MSAC advised the Minister of their views on the 30th of April 2020, and the Minister accepted those views. I'm sure the failure of the submission would have been very disappointing to the College and to all of you. I also understand that quite rightly the College does not regard the matter as now closed. It is not, and the College is currently working on a new submission. On the advice of MSAC, the new submission, however, will not be going back to MSAC, it will be going to the department, and I think that's quite an important thing to remember. I'm not entirely sure how any new submission is going to differ from submission 1344.2. Rob would probably be able to provide insight onto that. I would, however, like to share some extracts from the material I have read and also put forward a few thought-provoking suggestions. So the first extract comes from MSAC, and it reads, MSAC did not support that podiatric surgeons be given access to the requested MBS items. This was because there was not enough evidence to show that podiatric surgeons could deliver the same or better clinical items when compared to orthopedic surgeons. However, MSAC notes that this did not necessarily mean that services provided by podiatric surgeons are not as good as those provided by orthopedic surgeons. A bit of smoke and mirrors there. In relation to the evidence of clinical outcomes, it is interesting to note that MSAC did not state that the College itself had not provided enough evidence on clinical outcomes. The College had in fact provided considerable data on clinical outcomes, and that data was from your annual audits. This data, as I said earlier, showed that complications for patients who had undergone podiatric surgery were either within or below rates reported in the relevant literature. The problem, it's a bit of a cute point really, the problem was that the relevant literature does not currently include comparable Australian data relating to Australian orthopedic foot and ankle surgery. So there is no data from the orthopods, but there's plenty of data from podiatric surgeons. So my comments are, if there's no data currently available, and I guess we could ask the Orthopedics Society to collect it, or we know the answer there. If there's no data available which enables a direct comparison of clinical items between podiatric surgery and orthopedic surgery to be made, is it worthwhile in the College commissioning research which will enable indirect comparisons to be made? And I'm sure the University of WA may be able to assist in this respect. Secondly, currently data has only been reported in relation to adverse clinical outcomes, i.e. cases which went wrong. So I wonder if it's time to supplement the College's existing reports by also including clinical outcomes from all cases, both those that went wrong and those which went right. In saying this, I understand that it will take some time to develop agreed measures of good clinical outcomes. The next couple of extracts deal with whether or not it might be tactically better for the College to propose a set of new item numbers and descriptors for use solely by podiatric surgeons, rather than trying to piggyback on the existing orthopedic numbers. In this respect, there are two extracts. The first comes from MSAC, and it says, MSAC noted that the issue of whether two groups of practitioners should have access to the same MBS items or should have separate items, was primarily a policy and admin issue for the department. So they kind of washed their hands of that one. The next one comes from AMA New South Wales, and it reads, the AMA has significant concerns about providing access to MBS items which are currently only accessible by medical practitioners to non-medically qualified providers. Allowing podiatric surgeons to have access to MBS items for foot and ankle surgery sends a message to patients that podiatric surgeons are comparable to orthopedic surgeons in their training, safety and effectiveness. There's already patient confusion around the title podiatric surgeon, which is misleading in that it suggests they are medically trained. So my comments in relation to those extracts are, does it really matter if unique item numbers are introduced for podiatric surgery as opposed to using existing MBS orthopedic items? It obviously matters to MSAC. And what is of primary importance is that MBS rebates are obtained, not the method that is used to delineate them. Sure, the descriptor is important, but the actual item number is meaningless. And I think the college needs to be mindful of the fact, and you won't like this, but it has been a long-standing tradition of the MBS that only medical practitioners are able to use MBS item numbers. From an MBS point of view, and remember I'm talking about the MBS here, podiatric surgeons are not currently recognized as medical practitioners, even though AHPRA does. They are recognized as allied health providers. And today, the MBS provides rebates for 14 different disciplines of allied health providers, and each different discipline has its own range of item numbers. So I'm suggesting that tactically it may be better to push for a discrete set of item numbers to be introduced solely for podiatric surgery. If this was done, it will avoid one of the concerns raised by orthopedic surgeons, and will also solve the problem of MSAC not wanting to look at that issue. My only caveat to that suggestion is that if the college decides to push for new item numbers for podiatric surgery, it also needs to ensure that there are processes in place which will ensure that when and if these item numbers are introduced, they will automatically be assessed by the Theatre Banding Committee for the allocation of theatre bands. What that means is, and it is important because the allocation of theatre bands is the mechanism that is primarily used by private health insurance funds and private hospitals in determining what fees are payable for hospital procedures that are performed on the same day. So once you've got your item numbers, they've then got to be banded so that they can be assessed for health insurance rebates. In relation to AMA comments about the use of the term podiatric surgeon, I think we can all acknowledge that it is common parlance that a surgeon is a medical professional who performs surgery. But as we all know, the English language is filled with anomalies and contradictions. For an example, apart from podiatric surgeons, there are various other professionals who are commonly referred to as surgeons, even though they are not medical practitioners. And two come to mind straight away: dental surgeons and veterinary surgeons. Unless the AMA wants to outlaw those guys using the word surgeon as well. Right, the next thing I'd like to talk a bit about is sustainability. And what I mean by this is, I think it's important that we make sure that podiatric surgery is an attractive career option. From what I can gather, there are currently very few accredited podiatric surgeons in the country. In fact, less than 35. I also understand that for the 2023 intake into the college's podiatric surgery training program, there's only likely to be 2 or 3 positions available. I believe that with these low numbers, the college remains very exposed. It urgently needs to implement policies that will see that number increase as quickly as possible. Obviously, any policies will need to address current entry barriers to podiatric surgery, and so the college needs to make sure it thoroughly understands what those barriers are. Based on the research I've done, I think one of the most significant entry barriers relates to financial reward. As we've already seen, after having completed a 4-year undergraduate degree in general podiatry, it will still take aspiring podiatric surgeons another 8 years before they'll be able to achieve fellowship with the college. As medical speciality goes, that is reasonable. However, I would like to read to you the following extract from the FAQ page on the college's website. And it reads as follows. The ACPS strongly advises internationally qualified podiatric surgeons to carefully research the Australian healthcare system and the current position of podiatric surgeons in this system prior to making a commitment to immigrate to Australia. In Australia, the health system provides no funding support for podiatric surgeons, irrespective of qualification and experience. This will provide a significant limit in ability to practice. Now, I do commend the college for signalling its concern, or this concern, to international podiatric surgeons who might be contemplating migrating to Australia. But surely this extract tells us all that one of the most significant barriers to entry is the uncertain financial reward that podiatric surgery may offer newly fellowshipped podiatric surgeons. As we've seen, at the moment, the vast majority of the costs for podiatric surgery have to be met by the patient. Nothing is paid by Medicare. And even if the patient has private health insurance, the patient's health insurance company will pay very little or nothing at all towards the fees of the podiatric surgeon and only part of the hospital costs, the only exception being HCF and WA. Now, if I was a graduating general podiatrist in Australia and thinking about doing a further 8-year study to become a podiatric surgeon, I think this financial uncertainty would be a significant deterrent to me. The other significant barriers to entry is to do with the shortage of qualified podiatric surgeons who are prepared to do the necessary supervision and mentorship of a podiatric registrar who are within the training program. And with less than 35 registered surgical podiatrists nationally, that's not at all surprising. But the college needs to do better. I don't know what the attrition rate is in the training program, but even if it is nil, I very much doubt whether 2 or 3 new podiatric surgeons per year will be sufficient to replace current podiatric surgeons who may be considering retiring, dying, or leaving, hopefully not considering dying, in 2023, let alone enable there to be any real increase in the number of practicing podiatric surgeons in Australia. Another entry barrier is the difficulty podiatric surgical registrars find in reaching the minimum number of large surgical procedures in foot and ankle surgery that they've got to reach, which is around about 2,000. Now, because there are no public funded podiatric surgical services in Australia, all podiatric surgery is performed in private settings. I'm not sure what's involved in opening up the public sector to surgical podiatry, but obviously if this was achieved, it would significantly increase the cohort of patients who would benefit from such surgery, and this in turn might make it easier for podiatric surgical registrars to reach their required benchmark of 2,000 log procedures in foot and ankle surgery. Right, let's look a little bit about advocacy. Because time is running short, I'll have to be quite quick with this one. I think we are all agreed that strong advocacy is absolutely essential in the healthcare sector. Without it, it is quite likely that the subsector in question will over time wither on the vine and die. The question, of course, then is how does the college go about ensuring that its best interests are being advocated for to relevant stakeholders? I can't answer that simply for you today. But what I can tell you is a little bit about what Day Hospital Australia, DHA, what it has done over the last 2 decades to get to where it is today in terms of being recognised as the peak industry body for private day hospitals. And we are, the day surgeries were very similar to podiatric surgeons, really, in that we were seen as the poor cousins of the APHA, and in a sense you're seen as the poor cousins of the orthopaedic surgeons. Now, day hospitals were originally represented in Australia by a body called the Australian Day Surgery Association, which was registered with ASIC in 1992. At that time, the association was run and governed entirely by volunteers. And it's true to say that its ability to influence and affect government policy was minimal. In its early days, the association did not look things at all on a national basis. State-based interests took precedent over national interests. Consequently, the body that the federal government would look to when it came to understanding what day hospitals did and how they ran was the APHA, not the DHA. And in 2009, in a move designed to curtail state-based jealousies, a new board of DHA was established, and it had equal representation from all states and territories. However, at that time the board positions were unpaid and there was no CEO. Over time, a small number of part-time staff had been appointed, and they in the main provided admin-type duties. In July 2014, the first CEO, paid CEO to DHA was appointed, and that was a part-time paid position. Since then, the position has evolved into a full-time paid position. In 2016, a new brand was implemented and the organisation was renamed Day Hospitals Australia. As the peak industry body, the major function of DHA is to advocate nationally for the sector to all relevant government and industry bodies. Today, approximately 70% of all registered day hospitals are members of DHA, and DHA is definitely now the go-to peak body when it comes to sectoral representation. So much so that during the early days of COVID, the then Minister of Health, Greg Hunt, liaised closely with DHA in terms of all the changes that were made to Medicare in terms of telehealth. Now that change has not occurred quickly and not without a lot of effort. But in my view, the changes that have had the most significant impact on the culture and effectiveness of the organisation were when it moved from being largely an organisation run and managed by volunteers to a professional organisation run by a paid CEO and chairperson. That's not to say that the roles of volunteers are not important. Obviously, that is not the case. And DHA still relies very heavily on members to sit on both ad hoc and standing committees on a voluntary basis. But the CEO and support staff of DHA are now all paid employees, and the chairperson is paid a reasonable honorarium. If the college wants to effect change in the organisation, this is best done by a committed, professional and energised leader whose mission is to bring about the change. If that leader is trying to achieve that goal on a voluntary, part-time, unpaid basis, it's going to be extremely difficult. Obviously, it takes money to employ a paid CEO and support staff, and also to pay an honorarium to a chairperson. So these paid positions will only emerge as and when the college is financially stable enough to support such paid positions. Well, ladies and gentlemen, that brings me to the end of my presentation. I think we're going to break for coffee, are we? And I'm sure there'll be discussion over coffee, and then we can come back after coffee and perhaps tease out some of those ideas a bit more. Thank you.